Let's talk about sodium, one of the main electrolytes in the human body. We're going to consider sodium the fluid balance boss, and let's see why. So, sodium is one of the most important electrolytes that you'll see in regards to fluid and electrolytes, and also one of the most important ones that you'll see on the NCLEX. If you remember nothing from this video, remember this. Sodium helps to control water, and water usually follows sodium. So let's make sense of this. First off, where does sodium live? Sodium lives outside of the cell in what we consider the extracellular space or in the extracellular fluid. Sodium's normal value range is 135 to 145. Now, here's why sodium matters so much. It directly affects fluid balance, which means that it affects cell size, and that is especially important because it affects cell size in the brain. Sodium moves through the body using the sodium-potassium pump, as shown in the picture here. The membrane in between these cells help regulate where sodium and potassium go. This is a form of active transport. Sodium is also regulated by two major hormones, ADH and aldosterone. ADH is responsible for telling the body to hold water. So what does ADH stand for? It stands for anti-diuretic hormone. In pharmacology, you'll learn that diuretics are used to actually excrete urine from the body. When patients utilize a diuretic, it removes fluid through urine, so they'll have more urinary output. But an anti-diuretic hormone is going to reverse that or stop the water from leaving. It's actually going to hold or retain the water inside of the body. Aldosterone, the other hormone, it is going to be responsible for holding on to sodium. So anytime these two hormones are off or imbalanced, sodium can also potentially be imbalanced. Let's simplify sodium imbalances. This can become overcomplicated sometimes. I want you to think low sodium means too much water, and high sodium means that there's not enough water. For example, the patient might be dehydrated. For low sodium, we call this hyponatremia. This is when sodium levels are less than 135. The body is usually diluted. This can be caused by having too much water on board from conditions like SIADH. It might be from diuretic use, actually making sodium leave the body, vomiting, diarrhea, or even heart failure. In heart failure, oftentimes the patient's holding on to too much fluid that could dilute the sodium. For too much water, remember, sodium will be diluted. In high sodium, we'll call this hypernatremia. These values will be greater than 145. In hypernatremia, the body does not have enough water. It's what we would call maybe dehydrated. This can be caused by a condition, diabetes insipidus, can be caused by fever, sweating, or tube feedings that are given to the patients that do not have enough water in them. So it'll make the patient become dehydrated, but also have a high amount of sodium. So remember that water loss will equal sodium concentration. Something to ask yourself when you do come across a sodium-related NCLEX problem is ask yourself, is this patient gaining water or losing water? Remember, if they're gaining water, sodium may become low. And if they're dehydrated, sodium will become concentrated and increase. So what will this patient look like? This is extremely important to be able to recognize when there are symptoms of sodium loss or sodium gain occurring in the body. Sodium should be directly related to the brain. So if there's one thing to remember about sodium, it's that it relates to the brain. Most of the patient's symptoms will somehow come back to where the brain is connected. With low sodium, the brain can be swollen because there's a lot of water instead of sodium. So water is moving into the brain cells. These brain cells will become swollen. And what you'll see in your patient is a headache. They might be confused. They could start having some seizures, or maybe even become lethargic. Now, when the patient's sodium goes high, there's not a whole lot of water because water is moving out of the brain cells. So those brain cells will shrink. This patient will seem very restless, irritable, may also have some seizures, and even could go into coma. NCLEX tip for sodium symptoms. If you see neurosymptoms, especially confusion or seizures, you might want to think that sodium is the culprit here. So think sodium with the brain. All right, this slide has a lot of information on it, and this is where NCLEX questions will live. It's going to be asking what the nurse does, what your priorities are, what you're looking for. So let's take a look. Your priority assessment will be you're going to be looking for neurological changes, so doing your neural assessments. You should be watching for changes in the patient's level of consciousness, if there's any acute changes of confusion or even seizure activity, and creating some seizure precautions to keep that patient safe, like oxygen and suction at the bedside, bed in the lowest position, and even some pads along the patient's railings. For treatment, there is some different treatments whether you're having low sodium in the patient or high sodium. So with low sodium, we actually need to restrict fluid. There's already too much fluid in the patient. That's what's kind of taking over the space instead of sodium. So we would need to also give hypertonic solutions. Hypertonic meaning, again, remember from our previous videos, a lot of concentration or a lot of sodium in that solution. So we would give, for example, 3% normal saline. And if we can, we also want to try to treat the underlying cause that is causing the low sodium. For patients with high sodium, we're going to give them fluids this time. We want to encourage oral hydration, and we want to give them hypotonic solutions that has a lot of water and a little salt. And again, if we can, treat the cause of that high sodium. The patient, we need to do a lot of education with regarding the types of foods that they should eat or stay away from, depending on what their sodium levels are doing. Salt is one of the biggest sodium contributors to increased sodium in the patient's diet, as well as processed foods and everything that's basically preserved at the grocery store. Now for a huge safety point, you never want to correct sodium quickly. We want to make sure that we correct it slowly. Problem with correcting it too fast is that we can actually cause brain damage by making those brain cells swell or shrink too quickly. So on the NCLEX, if you are ever given an answer that says, hey, you need to fix sodium quickly or rapidly, that usually is not the correct answer because we have to do it slowly. A nurse is caring for a patient with a sodium level of 128. Which assessment finding requires immediate intervention? Go ahead and pause the video, take a look at the answers, and figure out what you would choose. All right, so our patient's sodium level is 128. And remember, sodium affects the brain. So if we look at our answer choices, which one relates to the brain? Is it muscle cramps, confusion, nausea, or dry mouth? If you picked B, confusion, you are correct. Confusion is a neurological change. Therefore, it would be a priority related to the sodium imbalance. NCLEX tip: when in doubt and you have a sodium question, pick the answer that's involving neuro changes. Question number 2. A patient with hypernatremia, a sodium level of 150, is being treated. Which provider order should the nurse question? Go ahead and pause the video and think about your answer choice. Will it be A, administer IV hypotonic fluids, B, encourage oral water intake, C, infuse 3% saline at a 150 ml per hour rate, or D, monitor neurological status? Go back to the main question. It asks you which provider order should the nurse question. That's like asking you which one is wrong. What would be the most inappropriate thing to do for this patient? What would make them worse? If you chose C, infusing 3% saline, you would be correct. That is actually the worst thing we want to do. The patient already has high levels of sodium. If you give 3% solution, you are giving a water solution with a lot of sodium in it, so we would just make the patient worse. We would want to give a diluted solution. We don't want to increase that sodium. And practice question number 3. The nurse is caring for 4 patients. Which patient should be seen first? So taking a look at these patients, they all have sodium lab values, but a symptom. The first thing you might want to do is just look to see which levels are abnormal. If they're all abnormal, and it looks like they are, then we're going to have to use the patient's symptoms or assessment findings to determine which one needs to be seen first. Pause the video and come up with your answer. All right, guys, if you chose C, the patient that has a sodium of 125 but also is confused, you are correct. That is actually the patient that needs to be seen first. Now, all other choices, their sodium levels are abnormal, but their symptoms aren't as prioritized as what a patient with confusion, so those neurological changes. Remember, with sodium, the brain tends to always be affected somehow, and if the brain is infected, that patient might become unstable pretty quickly. So we always want to look for a symptom that's related to any sort of neurological changes. So let's wrap this up with some important takeaways. First, when you think of sodium, think of the brain. When you're thinking and looking at lab values that relate to low sodium, think that the brain is starting to swell. High levels of sodium, the brain starts to shrink. Make sure that you are always doing neurological assessments. This would include the level of consciousness of the patient and also assessing for changes in confusion or active seizures. And most importantly, never correct sodium quickly. If you can remember these key ideas, you'll be able to answer most sodium questions correctly, even if that question does look a little complicated.